Scientifically speaking, we're sharing the view. From labs to clinics, breakthrough shining through, with minds that inspire and stories to unfold. Scientifically speaking, the future's being told.
Welcome to another episode of Scientifically Speaking with Christine on Oz Arab Media. Today, we're discussing one of the most talked about areas in endocrinology and metabolic medicine. It's the injectable medications like Mounjaro and Ozempic that are being used for type 2 diabetes, weight management, and appetite regulation. These drugs are often called the fat jabs in the media. They are transforming how we approach chronic disease, but they also come with important differences, benefits, risks, and clinical questions. Revisiting us today is Dr. Anis Irani. He is a reviewer for the British Medical Journal and an experienced endocrinologist to explain what these injections are, how they work, how they differ, and what patients and clinicians need to know from a scientific perspective. Dr. Irani, welcome back to the show.
Thank you very much, Christine, for having me. Thank you.
Of course, always a pleasure. Doctor, for the listeners who aren't familiar, if you can please tell us what class of medications does Mounjaro belong to and what underlying mechanism makes it effective for diabetes and weight management?
Sure. So Mounjaro is the trade name. The generic name is tirzepatide. It's what we call a dual agonist. So basically, it acts on two separate receptors. The first being the glucagon-like peptide 1 receptor, and the second one being the gastric inhibitory polypeptide receptor. And basically, if you remember, Ozempic or semaglutide is the generic name, acts on one receptor, which is the GLP-1, whereas the advantage of Mounjaro or tirzepatide is that it acts on two receptors. It's what we call a dual agonist. And of course, in the pipeline, there are triple agonists, which act on GLP-1, GIP, as well as glucagon. I shouldn't say in the pipeline because they're already out, but they're not available yet in Australia.
Yes. Oh, wow. That is amazing. So if we want to make it into simpler words, Mounjaro is acting not only on our hormones, it's also acting on our appetite or stressing appetite. Is it?
Sure. So the actual, I find this is the best way to understand what's going on with all of these molecules and all these drugs, is that back in the 90s, we had a very simple model for how sugar regulation worked in our human body. So basically, we had sugar in the bloodstream, our pancreas or our beta cells in our pancreas react by making a hormone called insulin. Insulin takes the sugar out of the bloodstream and puts it anywhere else, usually around the waistline, as in the form of fat or around the liver or internal organs. And that was the model that everyone accepted in science. And it was pretty simple, but it worked pretty well for a long time, until someone decided to do an experiment and basically wanted to give glucose or sugar orally, so by the mouth, and measure how much insulin the body made, and also to give sugar intravenously and measure how much insulin the body made. And everyone was like, well, it sounds pretty obvious that you're going to make more insulin when you trigger the body intravenously rather than orally. Like, well, what are we doing? And that's when everyone, the science world, was shocked to find that when we take sugar by mouth, we trigger a more efficient and a higher insulin release than intravenously. And that was deemed, or was called, the incretin effect. And the incretin effect is basically what summarizes what all those molecules are. So the incretins are a group of molecules that are made by our small intestine in response to a meal. And those include glucagon-like peptide 1, GIP, as well as glucagon. And this is independent of anything that's going on in the pancreas. So the pancreas is still going to go and do its job, and the beta cells are going to make insulin, and the alpha cells are going to make glucagon. But this is an independent effect that is mediated or basically orchestrated by the small intestine. And that's how we got interested in this to start off with, by the incretin effect. So If I may, I'll leave that point aside for a little bit, and I'll just move. I'll tell you what the. So this is the how we found out, but
Yeah.
the why is even more important. So
Right.
for a very long time in type 2 diabetes, we were after a medication or a drug
Yeah.
class that would basically regulate the blood sugar, not lower the blood sugar, just regulate the blood sugar back to normal levels,
Yeah.
as well as somehow reduce the waistline. Why were we doing that? Well, basically, in type 2 diabetes, there are microvascular complications and there are macrovascular complications. The microvascular complications, very simply, are diseases of the eyes, the nerves, and the kidneys. And if we control the blood sugar really well, we control the effects of diabetes on the eyes, the nerves, and the kidneys. However, if we only just control the blood sugar levels, we only protect the eyes and the nerves and the kidneys. To protect the heart attack risk, the stroke risk, and the risks of peripheral vascular disease, we need to reduce the abdominal waist circumference, or how much adipose tissue or fat is around the waistline. And this is where the interest for finding a medication that would do both, lower the blood sugar or regulate the blood sugar and at the same time reduce the waistline. For a long time, all we had was blood sugar lowering agents such as insulin and sulfonylureas. And yes, they were very effective at lowering the blood sugar. However, they carried the risk of lowering the blood sugar down too low,
Yeah.
or and also increasing the waistline, which is not a desirable effect because that increases your heart attack and stroke and peripheral vascular disease risk. So this is the why. Why were we after a class of drug that would reduce or regulate the blood sugar with very little risk of a hypoglycemic episode, at
Right.
the same time targeting the waistline? And this is the why. The how was the incretin.
And this is what Mounjaro actually does at the moment, and
Correct.
why it's taking the whole hype about it.
Yeah.
Amazing. Doctor, if you can tell me briefly, describe your clinic experience with these medications with your patients. What brought you specifically into treating metabolic diseases with these agents?
So for a long time, we focused on treating end results in medicine. And right now, the entire medical world is shifting towards preventative medicine. And those drugs are proving their efficacy in preventing the progression to type 2 diabetes, in
Right.
prevention of progression of non-alcoholic fatty liver disease into, for example, steatohepatitis or liver fibrosis. So the fat that accumulates on the internal organs is very harmful, and the metabolic syndrome is basically a collection of clinical features and laboratory features that reflect the patient's cardiovascular, cerebrovascular risk. And if we really only start our treatment after the patient has had a heart attack or a stroke, well, we're just mitigating damage or further damage. But the whole medical world has shifted now to preventing the heart attack or the stroke to start off with.
So that's mainly what you're experiencing in your clinic for you to shift to those types of agents.
Absolutely.
Amazing. And now you mentioned earlier that the Ozempic and the Mounjaro are from two different active ingredients. I'd like to know, how are they similar biologically?
So biologically, so basically semaglutide, which is Ozempic, is a glucagon-like peptide agonist, GLP-1 agonist. And tirzepatide is a dual agonist. So it covers the GLP-1 and it also targets a separate receptor called the GIP. So semaglutide is a mono agonist, if you will, and tirzepatide is a dual agonist, and retatrutide is a triple agonist. And basically, we find from studies and from all the data that we have, the more agonists that we're targeting, the better the outcome has become in terms of diabetes, type 2 diabetes management and progression to type 2 diabetes, fatty liver disease, and all that sort of stuff. Of course, now there's a little note here.
Yeah.
The semaglutide is older than tirzepatide, so Ozempic is older than Mounjaro. So Ozempic will naturally have a lot more studies to back it. But that's not to say that tirzepatide is not one day will have the same studies. but it's just a matter of time lagging behind. So right now, for example, as a case of fatty liver disease, we currently have a very robust trial backing like an evidence-based approach that backs semaglutide in the the use of semaglutide in fatty liver disease, whereas we do not yet have one as robust for tirzepatide. Does that mean that tirzepatide isn't going to provide the same benefits? Well,
Exactly.
no, I doubt it. It's just a matter of time before we have that.
Before we do. So just to wrap things up, you mentioned that Mounjaro in the research has works on as a dual, while Ozempic works as one. And excuse me if I'm using Ozempic and Mounjaro, but that's how we know it as community.
Yeah.
What, let me say that again, rephrase it. The difference that you've explained it, how do you consider deciding whether a patient might benefit from the Mounjaro versus the Ozempic or even Wegovy that goes in the same family?
So sure. So let's first of all, to answer that question, I probably should give you a bit of a background about why Ozempic got the hype or Wegovy. So Wegovy and Ozempic are the same drug. It's the active ingredient is semaglutide. Now semaglutide is a monoagonist, as you just said, so it targets one receptor.
Yeah.
Now, was Ozempic the first drug that targeted one receptor? Of course not. So we've had drugs for a long time that were GLP-1 agonists. So ever since that experiment that I told you about, drugs started being developed, and we had medications such as exenatide. The trade name was Byetta. The weekly exenatide, which is the trade name was Bydureon.
I think people used everything at the phase when Ozempic was disappearing from the market. Sorry.
Sure.
Yeah.
And we had liraglutide, and we also had dulaglutide, which is Trulicity, which is still in use. So what sets semaglutide apart from all those other molecules? So basically, semaglutide had a higher human homology, which means that the molecule looked a lot like the molecule that we make naturally. Whereas exenatide, believe it or not, was derived from lizard spit. So exenatide, the drug, was actually derived from an animal, and it only had something like 50 or 55% human homology. So it was only 50 to 55% identical to our own receptor, which meant a few problems. Well, basically, it's not going to be triggering the receptor as efficiently. Also may trigger antibodies against it because it doesn't look, our immune system may not like it. So semaglutide, basically, the human homology was not the only thing, but one of the major things that set semaglutide in its efficacy. And when I say it's not the only thing, it's because liraglutide, for example, which was marketed as Saxenda, had a very high human homology as well, but was not nearly anywhere as effective as Ozempic or Wegovy. So back to your question. So what do I do in clinical practice? So basically, I basically tailor it to the individual. There's a lot that goes into how I make my decision. So to summarize it and simplify it, some people who can tolerate Mounjaro cannot tolerate Ozempic, and vice versa. And some people can't tolerate both classes of drugs. So some people can't tolerate Ozempic or Mounjaro, and some people can tolerate both. So if someone can tolerate both, I'm probably going to go with Mounjaro. And the reason for that is because Mounjaro will result in a greater weight loss compared to Ozempic.
Okay.
Because of its dual agonist nature. Now, when will I use Ozempic over Mounjaro? I probably will use semaglutide over tirzepatide in instances where the person can't tolerate the tirzepatide. This has to do also with the way that we have something called pharmacokinetics, which basically summarizes how a drug gets absorbed into our body, how it reaches steady state. So a lot of the side effects you can actually correlate depending on how the drug actually gets absorbed. So for example, semaglutide has, which is Ozempic or Mounjaro, it has a 24, 48 hour peak, and then it stabilizes in the system. Gulaglutide Trulicity, which I talked about, it doesn't do that. It's basically has a straight line throughout the week. And how does that translate to in clinical practice? Some patients say to me, "Yeah, I take the Ozempic or the semaglutide. It constipates me for the first couple of days, and then I'm fine." Whereas when I took the Mounjaro, it constipated me the whole week. Now, that's not every person, but
so it's really very much a patient-targeted decision.
Correct.
Doctor, I would want to expand on how we started taking these medications for weight loss rather than diabetes. But before I go there, a lot of people were hyping Ozempic to a point where it went out of market. But now we're hearing a lot that, oh my God, Mounjaro is giving me much better results. What's your comment on that?
So basically, I have probably a bit of a reserved opinion on all of these medications when they're used for weight loss. The first thing I tell my patients when they come for wanting a consult about those medications, the first thing I say is that I do not care about your weight, because your weight is made up of your bone mass, your muscle mass, your fat, your adipose tissue. If we're talking about reducing your muscle mass, well, I'm like giving you prescribing a medication that's going to really hurt you. Okay. So the first thing I want to emphasize is that these medications have to be taken in conjunction with a very specific diet program, a very specific weight resistance exercise program that targets all the muscle groups to prevent or mitigate, at least, because we don't have any data yet, the amount of muscle loss that we will experience. Now, the drug companies will come and say, yep, semaglutide or Ozempic reduces your muscle mass. However, it increases your muscle strength.
Okay.
But even then, and when we talk about muscle mass, we're talking about muscle fat and muscle itself. And it's a really complicated topic to talk about, because when you talk about how are you going to measure what the muscle mass loss is going to be, well, they used volumetric MRIs, which basically tried to summarize how much or how big the loss was. But does that really, and that's when that doesn't really translate to muscle strength. So I think the safest way at the moment, until we have more data, is that you tell your patient, we need to focus on a low carbohydrate, high protein diet. We need to focus on regular exercise, both weight resistance exercise and cardio exercise. If you come and you've lost 20 kilos, remember that half of that could easily be muscle mass, because you haven't done the weight resistant training.
That's regardless if it's Ozempic or Mounjaro, right?
Well, that's even a more interesting question, because the studies so there's a ratio that they use in terms of the muscle to visceral loss, and tirzepatide claims that ratio to be 1-to-1, as in if you lose 10 kilos, 5 of that is muscle, 5 of that is fat. Whereas with semaglutide, it's 3-to-1. It's actually a little bit worse. But they say, well, but the muscle strength increases, so that's basically the things that the offsets. So regardless of which way you're looking at it, if there's so many different variables, especially age and peak muscle mass. So we achieve our peak muscle mass around the age of 28 to 30, same time that we achieve our peak bone mass, and after that we lose 1% of our muscle mass per year. So if you're giving Ozempic or Mounjaro to a 60-year-old, just remember that they've lost approximately 30% of their muscle mass. And if you haven't given it in conjunction to a regular weight resistance program, well, you're not going to mitigate the further muscle loss that's going to happen.
Okay, so maybe in human, let me say, community language. So Ozempic is not giving the hype anymore because it's less damaging for the muscles than Mounjaro?
No. I don't think a lot of people even know or care about the muscle factor.
Right.
Unfortunately.
Right. So would it be just a marketing campaign?
The effectiveness.
Marketing.
No, it's
It's
the
the
effectiveness.
effectiveness. So it is really Mounjaro that's more effective than Ozempic because of the
Absolutely.
dual
Yeah.
effect that it does. Wow, that is
Yeah.
very
So when you reach, and this is why I personally do not like to, for example, relate to you and to your
mm,
audience what the trials are, because the trials will say to you, well, tirzepatide, which is Mounjaro, translates into a 20% weight loss in 6 months, and that's when I go, hang on a sec, what weight loss are we talking? Or is that off the
yeah, or
waistline,
the
off
muscle
the
mass.
triceps fold? Where did that weight loss come from?
Mm,
Whereas semaglutide, when it reaches maximum dose, which is 2.4
mm,
milligrams, sorry, I shouldn't say maximum dose, because the most recent study pushed that to even 7.2
okay,
milligrams a week, which is pretty
okay.
high. But in terms of the 2.4 milligram dose, the weight loss achieved was about 15% per 15 months. So to recap, bariatric surgery approximately will result in an average weight loss of 40% in 12 months. Tirzepatide will achieve, when you get to the maximum dose, 20% in
That's
6 months.
Ozempic. Yeah.
Semaglutide, the tirzepatide
Oh,
as in
sorry,
Mounjaro.
Mounjaro. Yeah.
Semaglutide, which is either Ozempic or Wegovy
Yes.
at 2.4 milligrams, will achieve 15% in
Okay.
15 months.
Amazing.
If we go back to Saxenda, that was only 6%.
Oh, wow.
So
So basically, they're
see how we've
coming
evolved.
more in market because they're increasing the percentage because that's what the market is asking for, all the people.
Yeah.
Interesting. Now, going back to my point about these medications that were originally developed for type 2 diabetes, how have their uses actually expanded into weight management and metabolic health? And what evidence supports the shift?
So basically, when you think about it logically, it actually makes a lot of sense, because if you think about how type 2 diabetes develops, well, it develops in terms of that initial model that we talked about. Every time we
Yes.
eat carbohydrates, which break down to
Yeah.
sugar, our body makes insulin. The insulin stores the sugar in the form of glycogen around the liver, or adipose tissue around the waistline. This is an oversimplification, but just for everyone to really cap. So basically, how long does this process go on for? Well, basically, yeah, you want to say, okay, I'm going to keep eating carbs. I'm going to keep putting on a waistline. I like to use the analogy to my patients that if you bring food, from the outside, and your fridge runs out of space, where are you going to put the food? It'll be the freezer, and that's the human body. So basically, our fridge is our liver or internal
Mm.
organs, and our freezer is our waistline.
Mm.
So when you see that there's an increase in waistline, just know that your body is probably
Overflowing.
exhausted the space around the fridge, which is the internal organs. And that's not always
Yeah.
applicable, but that's just an
Amazing.
oversimplification. So then, let's say, how long can you keep going? Well, how long can you keep putting on waistline without developing diabetes? Well, eventually you will develop diabetes. Now, a lot of genetics come into play into how soon are you going to develop diabetes. So if you've got a first degree relative with type 2 diabetes, you're probably not going to get away with putting on a lot of weight before your body says, oh, look, I've made all the insulin I can make. I still can't get that sugar out of the blood. And that's when the doctor comes, oh, there's sugar in the blood. You've got diabetes. And that's basically what type 2 diabetes is. Whereas someone without an type 2 diabetes family history might get away with increasing their weight.
And that's
And
where we go
they
with the
basically,
preventive kind of treatment, which is those type of medications. Okay.
correct. The less waistline we have,
Okay.
the less insulin our body's going to make, the less waistline we're going to have. So it's a bidirectional. So we eat carbs, break them down to sugar. Our body makes insulin. Insulin increases waistline, and waistline increases insulin. So it's a bidirectional model. So when we try and say, okay, we're going to target this from every angle. First of all, we're going to say, okay, we're going to have a low carb diet. So we're not giving the body any excuse to make insulin. So we're having eggs for breakfast, salad for lunch, meat and veggies for dinner. So basically, there's no carbs in any of that, or very little carbs. So we're not giving any insulin. And then the second part is we say, okay, we're gonna do the weight resistance training, because we're trying to mitigate the muscle loss with Mounjaro, as well as, or semaglutide, as well as increase the non-insulin dependent uptake of sugar from the bloodstream. So when your muscles work, they soak up that sugar and they give your pancreas a bit of a rest. So your pancreas doesn't have to make insulin.
It doesn't.
And then we go with the injections as well.
Awesome. Now that these injections are becoming our heroes, really, what are some of the broader health impacts that patients might experience with these drugs beyond the weight loss or the sugar control?
So in terms of side effects, the most common side effects with these medications are gastrointestinal side effects, and that's what usually gets focused on a lot. And I like to pre-warn my patients and also screen them for conditions. For example, if you've got an underactive thyroid and you're constipated and I give you a medication that's going to slow down your bowels even more, well, I'm not doing you a favor. So going back to basics, going to how do these medications actually work? So basically, they work by at least 10 different ways, but I'm going to summarize the 5 most important ones. They send satiety signals to the brain. So they tell your brain you're full, you don't need to eat. They delay stomach emptying. So if you eat a meal, the meal is sitting in your stomach for a lot longer, which is why you get the reflux and the side effects that come with that. So that's an advantage, but it also carries disadvantages from the side effects. They slow down the whole gut. That's how you get constipated. This is why you get nauseous. This is why you might vomit, because this molecule is slowing down the digestion in your gut. Number 3, they tell the liver, stop making new sugar, a process called gluconeogenesis, which is the liver making new sugar. Number 4, pancreas, could you please, when you make insulin, can you please just make it not smooth and not react? So they regulate the amount of insulin that's coming out of the pancreas. So, and the 5th way, which in my point of view is the most important way, and it's triggering a process which is very hard to trigger in the human body, called lipolysis. So unfortunately, the body doesn't like to get...
Lipolysis is the breaking down of fat.
Correct, of the fat cell.
Yeah.
So, and the human body is very funny like that, because the human body will try. So if you starve someone, the first thing their body will get rid of is muscle and bone, not fat. Yeah. So they'll hold on to fat, and it'll be one of the last things that they want to get rid of. So lipolysis is one of the hardest processes in the human body to trigger. So what people have tried for a long time to trigger it with, for example, a ketogenic diet, which triggers lipolysis. This is part of why the body you lose a lot of weight with a keto diet, is because you've triggered lipolysis, which is one of the most stubborn ways or methods to trigger in the body. And unfortunately, this is where you can go wrong. So if you're doing a ketogenic diet, or you're doing whatever you do, starvation, intermittent fasting, if those individual muscle groups. So people say, for example, but I go for a walk, doctor. I'm like, okay, but what about your chest, your biceps, your back, your triceps, your shoulders? What about those muscles? When you walk, you're exercising your legs. What about the rest of your muscles in your body? So I think all the muscle groups need to individually be targeted, and no one's too old to start the process, as long as it's supervised and it's slow, and our bodies were made to exercise.
Amazing.
But if we haven't done it for a while, that's fine. We can get into the habit very slowly, do lots of stretching, do it under supervised, using gym machines, whatever limits the risk of injury, but we have to get started somewhere.
Have to get started. Lovely. We spoke about these medications' good side effects, but despite their popularity, they do cause some side effects that can affect the quality of life and maybe even more. So how do you advise patients about identifying normal side effects versus the ones that really need a medical review?
So we talked about the gastrointestinal side effects. We talked about the muscle loss, which is, to me, one of the major side effects. There are a few other side effects in the fine print that people need to be aware of. Now, are they really side effects of the drug, or are they associations? The answer so far to this point is we don't know. So I'm going to talk first of all about what commonly gets referred to as an eye stroke.
Okay.
And the medical term for this is abbreviated as NAION. So non-arteritic ischemic anterior optic neuropathy. So basically, we're talking about a loss of blood supply to the nerve that supplies our eyes, which is the optic nerve, which is
That's where you lose sight, or it becomes vague, and that's how people can know that they're getting this side effect.
Correct. Yeah. So you lose 80%, usually about 80% vision. It's not reversible. And so how often does this happen? So the incidence is estimated to be about 4 in 100,000 people.
Oh, wow. Now, nothing.
Have we established causality? The answer is no. So have we now unequivocally concluded that Mounjaro and or semaglutide, so tirzepatide or semaglutide, cause eye stroke? The answer is no, we don't know.
Okay, but what's the percentage of the people coming to you having this cause because and taking Mounjaro or Ozempic at the same time?
In terms of, so we have an association, we don't have a causality. So the association is 4 in 100,000 people who are on this medication can get this side effect. Now, why is it so hard for us to say that this is it the medication or is it not the medication? And the answer is the risk factors for developing eye stroke are the same risk factors that are present in the patients that we give semaglutide, Mounjaro, or Ozempic. So obesity, type 2 diabetes, cholesterol, high blood pressure, these are sleep apnea. These are the risk factors for developing eye stroke or NAION. And if you then say, okay, well, I think it's the drug, I'm going to stop the drug. Well, that's what clinicians were a bit confused. They said, okay, let's stop the drug. Okay. And other clinicians said,
eventually get it if you stop the drug.
So when they stopped the drug, nothing different happened. And when some clinicians chose to continue the drug because they said, well, the eye stroke risk factors are the cholesterol, the extra weight, the diabetes, and this medication is already fixing that. So why would I want to stop it? And we don't have conclusive evidence to say that medication actually causes this side effect. We know that it's associated, but we don't know that it causes. So I'm just going to continue with it, and that's fine. Some people continued the medications. So
in that case, doctor, sorry to cut you off. If a patient comes to you with this condition, would you leave the decision to them to continue or not continue the medications, or would you put your decision on it?
No, I would always be very diplomatic, and I would always say, look, listen, as far as we know, so the commonest question that I get is like, why don't you know? Why don't you know whether this is the drug that caused it or not? Like, you're supposed to know everything. Well, why don't you know that? And the answer is very simple. We don't have, so in medicine, for us to make a decision, we have to have something called a good quality evidence, which is a randomized, prospective, randomized, controlled, double-blinded study, which means all these criteria have to be met, and we have to sit down and say, okay, we are doing this trial to answer, what's the question we're trying to ask? Well, it's does Mounjaro or Ozempic cause blind eye stroke? Okay, let's divide. So how many patients do we need to answer that question? That's called, that means, is the trial adequately powered to answer the question? So to answer your question, why don't we know? All we have currently is observational data and not prospective randomized data. So we don't have a study that was randomized for that purpose. And I don't think we will.
Okay.
Because when we talk about something that the incidence of is 4 in 100,000, which means 1 in 25,000, it means that you're going to have to, you're probably going to need, I'm not a statistician, but you're probably going to need something in the 20s, 30,000 mark to be adequately powered to answer that question. So we don't have a conclusive answer, what would I do? I would explain that the risk factors for eye stroke are the same risk factors
And they'll take the decision.
that made us put you on Ozempic or Mounjaro to start off with. Right now, we have an association. We have some data saying that if we continue the drug, the vision's not going to worsen, for example, but we might mitigate some of the risks. And it's individualized. I've had patients say to me, no, I'm never going back to the injectables again because I don't want to lose eyesight in my other eye, and that's fair enough. And I've had patients say, yeah, I understand. I've got those risk factors. I may have developed eye stroke either way, so I'm going to continue mitigating my risk.
Awesome. Doctor, we also have been having safety warnings around mood changes or even depression and interactions with other medications, like the oral contraceptives with the drugs like Mounjaro and Ozempic. How do you manage these sorts of concerns in the practice?
So so basically, as of July 2023, the European Pharmacovigilance Group or Association, I forgot what it was called, received several reports of an increased suicidal signal in people who were taking semaglutide, which is Ozempic or Mounjaro. Now, what was the problem with all of that? Back to the same model. When we try to answer questions, we need good quality evidence, which is an RCT, randomized control study. So they say, okay, well, let's go back to the randomized control study that basically got semaglutide launched into the market. And let's have a look and see, was there an increased suicidal risk? And there was a big problem because in that original trial, the patients who had mental health disease were excluded from the trial. So people with depression were excluded from that trial. For people with untreated major depression were excluded from the initial landmark trial that So we couldn't answer it that way. So what do we do now? Well, we do the next best thing, which is we do know that when we don't give it to people with untreated major depression, we're not going to increase the suicide risk. It's only in those patients who are at risk of suicidality that we may increase their suicidal risk. Australia then in 2025 received about 72 reports so the Therapeutic Goods Administration, TGA, received 72 reports of suicidal ideation and or suicide in people who are on semaglutide. Let's not forget there's about 800,000 users of semaglutide in Australia.
Why in Australia?
So 72 is not a big number out of 800,000. And then this is the post-marketing realm that you've entered to, where you've taken a trial that had specific categories that were excluded, and then you started giving semaglutide to your patients, but you forgot that in the initial trial, the people with major depression were excluded. So then what would I recommend? I would recommend that if you have a patient with untreated major depression, that you do not prescribe semaglutide, and if they are on semaglutide, that you stop the semaglutide until we get further information about what this signal truly represents, because it may be a real signal and it may not be a real signal, but until then we should be cautious.
But what if the patient does not have any mental health issues, takes Mounjaro or Ozempic and reaches a point where they get depression or into a suicidal point? Is that related?
So whether or not it's related, I would just exercise caution and I would just take them off it.
Just same like the eye disease.
Correct.
Yeah.
Oh, well, not same to the eye disease because the suicidal risk is sort of like we're getting a convincing signal that so let's say someone was in their 30s and they didn't have depression, and then when they got to 35 they developed depression. Is that something that's unheard of? Of course not. People, that's what happens in life.
Yeah.
People may not be originally. So let's say that this person was also taking semaglutide, and then, well, who's to say that we don't know if the semaglutide caused it?
It's unknown, but they're related.
Yeah, but now that it's there, that's what's important. Now that the depression is there, that's what is important. So if the depression is there, and I think that there might be an increased risk, well, no, I'm not going to take that risk.
Right. What about the reduced effectiveness on oral contraceptives?
So this is very important. So basically, this got highlighted a lot in terms of the media, but what did not really get highlighted as much, which I think is even more important, is the fact that there's an entity called polycystic ovarian syndrome, which basically women present with irregular periods, which means that their periods aren't ovulatory cycles, excess hair because of the hormonal imbalance that happens, and more androgen or male type hormones happen, and high insulin levels. And you may or may not see cysts on the ovaries. That's not a required thing. So you can have 2 out of 3 criteria and still diagnose PCOS. Yeah. So how do you treat PCOS? Well, you treat it with a low carb diet. You give metformin, exercise, and you can give GLP-1s or Mounjaro.
Or Ozempic.
What happens when you treat PCOS? Well, they're going to go from a non-ovulatory cycle to an ovulatory cycle, and they're going to go a higher fertility rate.
Amazing.
Correct. So we should also remember that we should never use. So if someone's trying to actively get pregnant, they should stop semaglutide and on Mounjaro 12 weeks prior to even attempting to get pregnant. That's another point. Now, in terms of reducing the effectiveness of the contraceptive pill, yes, that happens with Mounjaro, as is the case with a lot of other drugs that we take. There's a lot of antibiotics that would do that. There's a lot of So
nothing really to worry about. Just if you really want to get pregnant, you have PCOS, treat yourself with Mounjaro, stop it, get pregnant, easy, done. Awesome.
Employ adequate contraception. Do not rely only on the pill. Make sure that you've got the 12-week washout, which basically is the washout period for that drug to get out of the system. Why do we know that Mounjaro and or Ozempic are harmful to the embryo? No, the answer is we don't know, and we don't want to have a study 30 years later saying, oh yeah, by the way, that medication, if you were exposed to it in utero, which means when you were in your mom's womb, now we know 30 years later. So the best way is to be cautious.
Amazing. Now, doctor, some people are accessing these medications without prescriptions or through unregulated sources, sometimes even imitation products, and unfortunately, they've been sold online. So what are the risks of that?
The risks probably are unquantifiable, because as I always say, if you don't have a diagnosis, you don't have a prognosis. If you don't know what is wrong with someone, you can't tell them what's going to happen next. And the same applies here. Well, we don't know what's in those drugs, so we can't tell you what's going to happen. Right. I personally don't know what is in those drugs. If a drug is unregulated, it could be in a number of things. It may have been sourced from a different country. It may have been I don't know,
preferably not
in a lab somewhere. So all sorts of dangers and unknowns arise from that sort of use. Yeah.
Stick with your doctor and do it the best way. Now, looking ahead, doctor, because we saw how these medications went from 6%, results up to hopefully closer to gastrointestinal which is of close to 45. So how do you see the role of these metabolic medications evolving now with the new agents coming into the clinical trials? Do you see them maybe getting rid of the surgeries in the future?
I think yes. The answer to that question is that part of the reason why bariatric surgery actually works, and this is a common misconception, is that people think that bariatric surgery worked because the stomach is now smaller, so less able to accommodate, a bigger meal. And that's not true. The reason why bariatric surgery actually works is because the body, the intestine specifically, starts to make more of those molecules that we're talking about, the monos, the GLP-1, the GIP, all those chemicals start to be made more post bariatric surgery. And this is why bariatric surgery actually works, is because your body now is reset into a state where it's making more of those peptides, and that's why bariatric surgery. Would it ever? Yes, I think medicine in general is heading towards a more refined versions, genes, cells. The more we are able to tackle the intervention that once upon saved people's lives. I'm not saying that, of course, it had a role at a certain time, but I think, yes, we are headed towards the age where medication, yeah.
Amazing. Before we end the questions for today, you did mention that in Australia we have very high consumption of these medications like Mounjaro and Ozempic, and the Australians would really love to know if they will eventually become covered under the Medicare's PBS or the Pharmaceutical Benefits Scheme, and what factors would influence the decision to a yes or a no.
So there's a lot of groundwork that's being done that's pushing for that. I am aware of at least 2 different pathways that have been pushed behind the curtains to try and make those medications more accessible, I suppose, for patients. So in terms of there's 2 different things in terms of the indication that the TGA would approve it for. For example, tirzepatide or Mounjaro is now approved for the treatment of sleep apnea.
Okay.
That's one thing, but the other thing is it's subsidized. The answer is no, it's not subsidized. So if you have sleep apnea, can you access Mounjaro on the pharmaceutical scheme? The answer is no. So I think, yes, we are heading towards there, and I think it will change. Unfortunately, change takes time, and but I think if you look at it logically, going back to the basics, we are treating metabolic syndrome, and at the heart of metabolic syndrome is targeting the central obesity. Which is what those medications do.
Nowadays, a lot of people say, oh, if you've got a specialist that's giving it for you, just let them write a report that, it is a chronic thing, you can't live without it, or you're a pensioner, or whatever the excuse is, they will put it under the Medicare. Right. But that's not the case yet, right?
No, okay. No. So there are certain indications, for example, for the veterans, the DVA will pay for it if a specialist rings and says, "Look, I think it's clinically indicated." Yeah, but that's the RPBS. That's not the PBS. That's for the veterans, the people who served in the Australian Army. And another way that people try and get around the finances of it is to have a compassionate release of their superannuation so that they can pay for the medication, because if they pay for the
but it's not the PBS.
It's not the PBS. The PBS has very strict guidelines in terms of using it in type 2 diabetes. You have to have trialed at least metformin, sulfonylurea, or insulin in conjunction with you would have had to trial a DPP-4 inhibitor and or trialed an SGLT2 inhibitor and still not achieved an adequate response, glycemic response, meaning sugar control. Yeah. And so there's nothing in terms of mentioning what the waistline has done, and that's something I personally disagree with, because when you look at diabetes, if someone with type 2 diabetes comes to my clinic and all I'm doing is looking at their sugar control, I'm doing half my job, because the other half is what's happening with their big vessel risk, with macrovascular risk, what's happening with their heart attack risk, stroke risk, peripheral vascular disease risk. That is to do with their waistline. So the PBS does not look at it like that. The PBS looks purely at a glycemic control point of view.
So PBS is really strict and it takes its time, as you've been mentioning. Do you think it can be sometime in 2026, or should we wait?
No idea.
No idea. All right. At least we tried.
I know there's been a submission by the pharmaceutical company. I have been made aware of that.
Yeah.
I don't know what the response time is going to be, and I don't know if it's going to be a positive response, and I don't know how it will translate into whether, for example, it's a full subsidy or half subsidy or whatever. Yeah.
Interesting. Now, towards the end of our show, I'd like to do some busting of myths. So, although we've already spoke about a few of them throughout our talk today, but how about I give you some statements related to the Mounjaro and Ozempic, and you tell us if it's true or false with a very little y. Let's try to make it sharp and quick and easy, please.
Okay, let's go.
All right. Once you stop these injections, the weight comes back double. What do you think? True, false, why?
Partially true
That's for
because
Dr. Anis to give me a sharp answer
Stop
without an
answer.
explanation.
33% of patients will not put the weight back on.
How much? Yeah,
66%
yeah.
will put the weight back on. 33 will not put the weight back on, which sounds like a horrible statistic. But in medicine, in the world of weight loss drugs, this is a great statistic. When you say that 1/3 of your patients are not going to put on the weight when they stop the drug, that is a great statistic.
Not knowing the circumstances around them specifically. So it might
Correct.
not be the drug itself as well, it might be them.
I tell all my patients this is a car, it's got 4 wheels: diet, exercise, power, willpower, and the medication. If you're only using the medication, not using the diet, the exercise, the willpower, well, your car is going to move very slow. But if you're using all 4, your car is going to move quicker, and you're going to preserve your muscle, and you're not going to put on the weight when you stop the drug.
Amazing. My second statement: if a medication helps you lose weight, then it is safe for anyone else to use.
Absolutely not. Patients could have all sorts of different undiscovered conditions. Constipation is very common in the community. There's sometimes hormonal issues that result in constipation that you can fix them before you start any of those drugs, because those drugs are going to make constipation worse, and they can be very dangerous if you're taking them unsupervised and without sitting down with a doctor that asks you about all those intricate details, those nuances. What's your bowel habit like? What's your food like? What do you eat?
It's very tailored.
Constipated, let's do a blood test, make sure you don't have anything that's going to predispose you to having more side effects when you use the drug. There's all sorts of things that go into it.
Amazing. My third statement, and I know I'm going to see that look on your face because we're already
seeing that look.
These injections replace the need for diet and exercise.
Absolutely
again,
not.
The car again.
Go back to the car.
Yes.
Unless you want to lose muscle mass, you want to sit there and you take this medication, you want to lose muscle mass, bone mass. If you're fine with that, yeah, but that's very unhealthy. And especially if you're a bit older. So how long would you like to preserve your independence for? How long would you like to keep walking without any walking aids? Well, that depends on your muscle mass, really. And, if you're going to waste the muscle mass just because you want to lose weight. Yeah.
Thinking of the now, not the later.
Absolutely.
The next one, more rapid weight loss always means that better health outcomes will be in the end.
Not necessarily. Rapid weight loss is associated with more risks, specifically, for example, acute cholecystitis, which is inflammation of the gallbladder, which can be very dangerous and very serious. Rapid weight loss is associated with all sorts of issues. Now, if you're doing it in a concerted effort, and I see a lot of my patients do it like that, and they do rapid weight loss because they're adopting a keto diet, a regular exercise program, and they're very careful how they escalate the dosages of the medications. Those people are fine. They do very well. They still have a risk, obviously, of cholecystitis, but they're in terms of. But it doesn't mean that more rapid weight loss. If you're doing more rapid weight loss without exercising, without eating healthy, no, that's actually really bad because you're losing a lot of muscle.
That's what we call maybe the sickly thin. The sickly thin. They don't even look good.
Exactly.
Our last one: side effects are just fine because it's just a sign the drug is working.
Not really. Side effects occur in about 5 to 15% of people, the commonest being the gastrointestinal side effects. Part of it, yes, if you're feeling full quicker and you're not feeling, hungry all the time, if you're considering that a side effect, yes, well, that means the drug is working. But other things, if you're getting, constipated and thinking, oh, yeah, that means the drug. No, yeah, you're suffering a side effect of the drug. And you need to mitigate the constipation. You need to eat more fiber. You need to drink more fluid. You need to walk a lot more. You exercise a lot more. And you may need some medications to mitigate the constipation.
Awesome. That
And it's
was
important to report all those side effects to your doctor, of course.
Yes, of course. Always work with the doctor. Dr. Irani, thank you so much once again for guiding us through this complex but highly relevant topic. And we are taking out of your time, so we really appreciate that.
That's okay. It's my pleasure. Thanks, Christine. Thank you
you so much.
Thank
And before we go, I'd like to tell our listeners, if you are considering or prescribe these injections, please always follow your endocrinologist advice and report any unusual symptoms. Understanding how these medications work helps you make informed health decisions. This was Scientifically Speaking with Christine. Until next time, thank you.
Thank you.